Hello, and welcome to the monthly Care Partner training. Today we'll be talking about Parkinson's dementia with presenter Dr. James Leverenz. He is an MD at the Cleveland Clinic, and he has been there since 2014, assuming the directorship of the Cleveland Lou Ruvo Center for Brain Health and the Joseph Hahn, MD, Endowed Chair of the Neurological Institute in the Cleveland Clinic. He got his undergrad at the University of Washington, has a postgrad in neurology from New York Hospital, Cornell Medical Center, and neuropathology from the University of Chicago. His primary clinical and research interests are the aging-associated neurological disorders, including Alzheimer's disease, dementia with Lewy bodies, and Parkinson's disease. He serves on the board of directors and professional advisory board for the Cleveland chapter of the Alzheimer's Association, and is on the scientific advisory council for the Lewy Body Dementia Association. Currently, he is the principal investigator for the National Institute on Health-funded Dementia with Lewy Body Consortium and a principal or co-investor on projects funded by the Alzheimer's Association, Department of Defense, Lewy Body Dementia Association, and Michael J. Fox Foundation. Insight has our mission to provide specialized care, support, and education for individuals in all stages of memory or cognitive impairment. Their partners and the community, and our vision is a community where those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. We are a leader in dementia care in Northern Virginia. Insight is a nonprofit that was started in 1984 that supports families on their dementia journey. In our care spectrum, we have specialized adult day programs for people in all stages of their dementia journey. Our connection is built by having relationships and supporting care partners on their journey, and our creativity with all of our dementia experts, sharing our knowledge and resources because every journey is unique. So I'd like to go ahead and welcome Dr. Leverenz, and he can go ahead and get started. Thank you for being here.
Thank you for the invitation, and give me a thumbs up if you can see my slides all right.
You're good.
Is that working? Okay. So again, thanks for the invitation to speak on a topic that I'm quite familiar with and have a strong interest in, both in terms of Parkinson's disease as well as dementia with Lewy bodies. And I'll go over some of those definitions as we move along. And I will do my usual disclosures here. So I received some funding from the GE Healthcare for a study on dementia with Lewy bodies where we use the dopamine scan, the DAT scan, and I've done some consulting for Citibank. Neither are really in conflict, particularly for today's talk. Overview-wise, what I want to talk about are the Lewy body associated dementias, and for those of you who aren't familiar with what a Lewy body is, I'll define that for you. What mild cognitive impairment and dementia are. Let's talk about treatment and then some of the research that we're doing in this area. So I want to start by defining what is dementia. And there's some pretty specific criteria that we use. And I'm not sure in the community, dementia is kind of a terrible term, but there's a specific way that we define it, which means that there's a change in a person's thinking skills that affects their ability on a day-to-day to do their usual activities, which can vary quite a bit based on the individual's baseline abilities. And that can be a change if they're working still, that they're having trouble holding on to their job, versus somebody maybe who's retired and there's less demands. It can be hard in Parkinson's disease because you also have the functional changes related to motor activity. Usually we like to see at least a change in thinking skills as defined by cognitive testing. That can be something like what we call a Montreal Cognitive Assessment at the bedside, or as much as a neuropsychology evaluation. But we want to see those two components for dementia, that change in ability of day-to-day functioning and a decline of some kind of that we can document. It's important to recognize that there are a number of people who fulfill these criteria who are really have maintained a lot of functionality. So we often think of the term dementia, we think of somebody, say, in a long-term care facility, but there are a lot of people who can spend time alone, et cetera. practical question I often ask is, if you had to leave town for a week, would that person be able to manage on their own based on their thinking skill issues? So again, it's a broad term, and it doesn't necessarily mean that it's a single cause underlying it. Parkinson's is one, dementia with Lewy bodies I'll talk about is another, Alzheimer's is obviously a third, a number of different kinds of dementias. Another term that we often use in the field is mild cognitive impairment. That generally means that the person hasn't really lost their ability to function on a day-to-day met in their normal day-to-day activities, but they've had a decline from a previous level, actually not so much of functioning, but a decline in their cognitive skills. So I have a lot of Parkinson patients who've complained to me that their multitasking abilities aren't as good as they used to be. They're still maintaining their day-to-day activity. And again, their spouses may say, yeah, I had to leave town for a week and they did just fine on their own. So not so much of a functional impairment as much as starting to detect a bit of change in thinking skills. So I'm describe a little bit of the history of Parkinson's disease, partly to give me an opportunity to talk about what a Lewy body is and how we link that to the two major Lewy body diseases, Parkinson's disease and dementia with Lewy bodies. So you can all see this classic picture from the 1800s of somebody who was originally described with Parkinson's disease. The resting tremor tends to be more on one side than another, increased tone in the muscles, slowness in movement, and often postural instability, difficulty maintaining balance once a person gets off balance. So those of you who've seen a movement disorder doc will know the so-called pull test, where we pull people and try to make sure they don't fall over and knock us down too. But that's sort of the classic 4 symptoms that we look at on the motor side. In the brain of someone who's died with Parkinson's disease, obviously we have a history of Parkinsonism. And what we see, and we've known for a number of years, is that there's cell loss in an area of the brain called the substantia nigra, which means substance black because the cells there are pigment, and I'll show you a picture next. We also see changes in something called the locus coeruleus, which is called blue spot because it looks a little blue when we look at it in the brain. And really, there are a number of other areas that can be involved as well, which kind of is more relevant to maybe some of the discussion we'll be having later about cognitive and behavioral changes. So we look at that brain stem here, and hopefully you can see my pointer here, but this is an individual who's died without Parkinson's disease, and you can see this substantia nigra. There's one on each side of the brain, and it's called substance black because the cells there have this brown pigment in them that shows up as black here. And it's a pretty normal looking substantia nigra on the left side. On the right is somebody who passed with Parkinson's disease. You can see the brainstem looks the same size. In fact, here it looks a little bit larger, but really have lost those pigmented cells, and we've lost that pigmentation. So we often call that depigmentation. That's really a sign that the cells there have died, and that the pigment has been picked up by the immune cells and taken away. So that sort of depigmentation we see. There are other diseases besides Parkinson's and dementia with Lewy bodies that cause this, but this is something we always look for. So as you can see, hopefully here as well, this is a microscopic view of a substantia nigra brain cell. So that brain, that area with the substance black I mentioned. So here's the cell here. And in the cell, you can see the nucleus that contains the DNA that all the cells have, and what we call the cytoplasm, where a lot of the activity happens in the cell. And in this particular area, you can see the brown pigment that makes that substantia nigra look so obvious when we look at it, what we call grossly. And in there, you can see, I hope, this round circular object here. And this is not a normal, what we would call inclusion. This is a Lewy body inclusion that Friedrich Lewy described quite a while ago. And you can see the normal, the halo that we tend to see, and then the center here, this sort of pinkish center in this particular kind of stain. So this is the Lewy body that we link to Parkinson's disease, and it's also linked to dementia with Lewy bodies. And in fact, we often see these in Alzheimer's disease as well, as I'll describe later in the presentation. These are other sort of normal cells without the Lewy bodies in them, but we do know that when the Lewy bodies happen, they seem to be associated with eventually with the cell dying, and then the loss of that dopamine that you try to make up with the dopamine medications that you get in Parkinson's disease. So for many years, we didn't know what a Lewy body actually was, other than we associated it with Parkinson's disease. Then there were some discoveries that individuals that had a mutation in a protein called alpha-synuclein that we all have. We all have this alpha-synuclein gene and have alpha-synuclein proteins that are important in how brain cells communicate with each other. But there were certain changes in that gene that caused people to basically develop Parkinson's disease. So that change, if you had it and you carried that, you were at high likelihood of developing Parkinson's disease. Pretty rare, but at the same time suggested this gene and this protein, alpha-synuclein, were particularly important in sort of the biology of Parkinson's disease and related disorders such as dementia with Lewy bodies. Kind of linking that even further, there were some very rare families where, we normally get from our one alpha-synuclein gene from our mom and one alpha-synuclein gene from our father. And we normally have just two copies total of this gene. There's some rare circumstances where for some reason, instead of one copy, we get two copies from one of the parents. So instead of having two total, we have three. Or even rare circumstances, we might have four that we've inherited. And usually it's because one parent is carrying more than one copy. In these circumstances, it's kind of like the mutation I just talked about. People are at high risk for developing a Lewy body disorder. What we did notice is in these, what we call duplication or triplications of that gene, is that they frequently will get more of a picture of dementia with Lewy bodies than Parkinson's disease. So they may present with a memory and behavioral change before they develop motor symptoms of Parkinson's disease. So this again really reiterated how important this protein, alpha-synuclein, seemed to be in the cause of Parkinson's disease and related disorders. Subsequently, antibodies were made to this protein, and when we went back to look at people who had passed with Parkinson's disease, with dementia with Lewy bodies, we actually could see that these Lewy bodies, in fact, here's one that's kind of looks like that one I showed you in the pink stain. These Lewy bodies stain for alpha-synuclein. This protein seems to be a component of these Lewy bodies. And in fact, it improved our ability to see it pathologically. And you can see here in this cell, actually, it has multiple lobules of Lewy bodies here and in here. And we were also seeing that there were processes that contained this synuclein protein in it that were abnormal. So it really improved our ability as a pathologist to determine how frequently did we see this Lewy body pathology in the brain. So how frequent are these Lewy body dementias, this sort of person who develops a change in their thinking skills that's affecting their day-to-day functioning in some degree? And we think there's about 1.5 million, almost 1.5 million Americans that have one of the Lewy body dementias, and I'll define these in a few minutes, but they comprise of dementia with Lewy bodies, patients with Parkinson's that later develop dementia, and what we sometimes call the Lewy body variant of Alzheimer's disease. What we know is that these are very difficult to diagnose, especially when it starts with the dementia before the Parkinson's disease motor symptoms, that people will often have multiple visits, on average, not get a diagnosis for several years. They may get inappropriate care, and they may get drugs that make their Parkinson's symptoms worse or their confusion worse. And of course, families and patients are distressed because they don't know what's going on. And this is just, you'll see this slide again, but this is a slide of some work I did. As mentioned, I've trained not only as a neurologist, but also as a neuropathologist. So a lot of my work has been how frequently do we see these changes of Lewy bodies in the brain of somebody who's had changes in their thinking skills. And you can see in this community-based sample I worked with when I was at the University of Washington in Seattle, that about half of all dementia cases had some of these Lewy body changes in the brain, often in coexistence with Alzheimer's disease, but sometimes alone as well. So in this circumstance, about 13% of all the dementia cases had what we might call Lewy body disease alone without coexistent Alzheimer's disease. So not an infrequent cause of dementia in the community. So we talked about the 1.4 million Americans in the US, again, some of the difficulties we've had. And at the end of this, I'll talk a little bit about some of the research that we're doing to really start to address these issues. I think mostly we've been very focused on how do we diagnose this accurately. I'll make this comment towards the end, but one of the things that's fed into the development of better therapies for Alzheimer's disease is actually that we're better at diagnosing it. We have what we call biomarkers to identify somebody who has Alzheimer's disease. And that really made a difference in terms of the trials. What we realized in retrospect is some of the early trials for Alzheimer's, some of the treatments, some of the people getting the medications actually didn't have Alzheimer's disease. And it wasn't until we actually could define it better during life with what these called biomarkers, and that can be imaging or blood or spinal fluid, that we could actually appropriately give these people the drugs that we were trying to see if it helped. And that really has led to these mild but significant changes that we're starting to see with the drugs for Alzheimer's disease. And of course, that's what we'd like to do for the Lewy body diseases as well. So I'm going to talk about the two major kinds of Lewy body dementia. There's Parkinson's disease dementia, which in a simple term means somebody has Parkinson's, they've had a diagnosis motor-wise. Usually I'm looking that they've responded to some of the motor therapies, and then later develop a change in their thinking skills. Dementia with Lewy bodies, which I'll talk about next, is somebody where they present mostly with a cognitive change, less with the motor symptoms, and then maybe later develop the motor symptoms. So it really depends on what starts first. So the clinical diagnostic criteria for Parkinson's dementia is that, again, you start with a diagnosis of Parkinson's disease and then later develop a dementia syndrome. And that kind of fits, again, the dementia diagnosis that we talked about earlier. So an impairment in thinking skills, a decline from a premorbid level, so before they developed any kind of symptoms, and its deficit severe enough to affect their daily life. So that's kind of the Parkinson's disease dementia diagnosis. So again, starts with the motor symptoms. So how frequent is dementia in Parkinson's disease? Well, I think an eye-opening paper that came out from Dag Arsland in Europe was that he was seeing in his cohort of patients that he was following with other people in Europe, so it's a European consortium, that people with Parkinson's disease frequently were developing dementia, as they were defining it, as high as 60% by 10 years of disease, and is almost up to 80% by 15 years of disease. This really opened our eyes to the fact that dementia could be a significant part of Parkinson's, particularly later in the disease process. In a subsequent paper looking at the same sample that he looked at, he also saw that many individuals had mild changes of, as we talked about earlier, that mild cognitive impairment, even early in the diagnosis of Parkinson's disease. So about 20%, not quite 20%, seemed to have some early mild cognitive impairment. So they were maintaining their day-to-day functioning. And again, as I mentioned earlier, I frequently see patients will tell me that they don't multitask as well, which is a change from the past, used to maybe be a strength of theirs. and that later they noticed as they developed Parkinson's, they also developed this issue, but could still manage most of their day-to-day functioning. So I think that the news from this particular study was that, quoting Dog in this paper, these findings highlight cognitive impairment as a key feature, maybe even early on in the diagnosis of Parkinson's, but certainly later on. So one thing that came out of this and was often thought, sort of people hypothesized, was in fact that people with Parkinson's disease that later developed dementia are older and they just happen to develop Alzheimer's disease. And this was a study actually we participated on with our colleagues at the University of Pennsylvania, looking at changes of Alzheimer's disease and Lewy body disease, Lewy bodies, as we talked about earlier, in people who develop dementia in the context of ongoing Parkinson's disease. And in this study, what we found was that Lewy body pathology, particularly the changes in areas outside of the substantia nigra that I showed you earlier, but in the thinking parts of the brain, the memory areas, and in what we call the cortex, those individuals, in fact, that was really what was driving most of the dementia that we were seeing in this pathway. There were some people, about 30%, or a little bit less than a third, who had coexistent Alzheimer's that may have also contributed to the dementia. But again, I think that the story out of this really was that individuals with Parkinson's disease, a lot of the dementia that we see is probably driven more by the changes that we link to Parkinson's than to changes of Alzheimer's, although there is a significant subgroup that do get Alzheimer's disease. So I did want to throw this caveat on, partly because I was reviewing and co-authoring on this paper that will be coming out of the Parkinson's Progression Marker Initiative study and out of the University of Pennsylvania. This paper and this study that was actually presented at the Movement Disorder meeting just earlier this year, and that they're looking to publish soon, was looking at trying to sort of re-examine the Dog-Arslan studies, particularly in a group that was really well characterized. So if those of you who don't know about the PPMI study, there's a Michael J. Fox Foundation sponsored study, really following people from the moment they were diagnosed with Parkinson's disease over a number of years. There was also a second, what we call cohort of patients that University of Pennsylvania has been looking at for many years. What they noticed in this study was that, in fact, when they looked at these two cohorts of people who were really followed very carefully, that maybe the frequency of development of dementia was not quite as high as Dog had mentioned. It's still fairly high, about 75 or 3/4 by 20 years of disease, and saw similar risk factors that the older you are, male sex, education levels seem to be, higher education levels seem to be protective, that it maybe wasn't quite as high as we'd seen in the Dog-Arslan study. So there's still a lot of debate going on. I don't think there's any debate that it's a frequent coexistent problem from Parkinson's, but it looks a little different typically than what we see in Alzheimer's disease, and many patients will go 10 and 20 years without developing dementia. Going to talk about the other side of the equation, the dementia with Lewy bodies. And this is a dementia with Lewy bodies is defined by somebody who presents to us with a dementia, as we defined it earlier, and some core features, including features of Parkinson's disease, the features of Parkinsonism, which is under 2C there. We also look for a number of other kind of somewhat unique characteristics to these individuals. We often notice that they have fluctuations, that they have good days and bad days. And we all have good days and bad days, but these individuals may have periods of time where they're almost like they're back to normal, and then others where they may have 36 hours where they're really hard to wake up and they're really confused, and then they bounce right back out of it. These individuals often have visual hallucinations. They see things that can be quite distinct, and they can describe them, and often they recognize that they're not real. So you have to make sure as a clinician that you ask the question, are you seeing things that other people don't see? Because they'll often say, well, yeah, I see this dog in the corner, but I don't know. I know we don't have a dog, so I know it wasn't real, but never mentioned it to anybody until you ask that question. And then we also link it to something called REM sleep behavior disorder, which we also see in Parkinson's disease, where people act their dreams out. So typically during dream sleep, partly so we don't hurt ourselves or our bed partners, we act out we are kind of somewhat paralyzed. We're still breathing, we still move a little bit, we may do a little talking, but we're not moving a whole lot. People with Lewy body disorders, either in the context of Parkinson's disease or dementia with Lewy bodies, will develop REM sleep disorder, often years before any other symptoms kick in. And in those individuals, they'll tell you they're acting out their dreams. Their spouse will often tell you that. You can diagnose it very accurately with a sleep study. And so many of my patients I'll send off for a sleep study, especially if they give me a hint that maybe something's going on there. There's some other changes that we look for that are what we call indicative biomarkers that we've also used in Parkinson's disease, particularly the DAT scan, the dopamine transporter scan. Something we rarely use is an innervation of the heart test. And again, that sleep study that we look for REM sleep behavior disorder. So one of the big debates in the field is, are Parkinson's dementia, Parkinson's disease, and subsequent dementia the same thing as dementia with Lewy bodies? Are we just looking at the same disease? And that's, from a clinical point of view, what we typically use when we're defining these two disorders is we use the so-called 1-year rule. So did the Parkinson's motor symptoms precede the cognitive changes, the memory changes, the multitasking, or the more severe impairment where it fits the criteria of your dementia? Did those precede that by a year or more? Then I'll usually put it in the Parkinson's dementia category. And as you could see from those studies that I mentioned already, that many Parkinson patients will be at 10 years and not have developed a frank dementia. Dementia with Lewy bodies, usually the dementia either is before the motor symptoms of Parkinson's or simultaneously or within a year of each other. And in that circumstance, we call it dementia with Lewy bodies. And those are just so we all know what we're talking about when we're talking about a particular individual or a diagnosis. So again, there's a debate. Are they variant of the same disease? I tend to think of this as, I'm a biologist at heart, that there's a biology why somebody presents with a motor symptom 10 years without development of dementia versus somebody who presents with the dementia and then and later develops Parkinson's. They're very highly related to each other. No doubt that if there's a specific treatment to treat the Lewy bodies, we're going to want to try it in both these patient populations. But for now, I tend to keep these two separate, even though they share many commonalities. So that sort of third component of Lewy body dementias, I talked about Parkinson's dementia, dementia with Lewy bodies, are Lewy bodies, and we see them in Alzheimer's disease. And I'll throw in one historical slide here. So on the right here is Friedrich Lewy, who described the Lewy body that we talked about already. And in this picture here, here's Friedrich Lewy when he was a trainee, and here's Alois Alzheimer that described Alzheimer's disease. So already early on, historically, the two were kind of linked together. So this is some work I've done over the years and been very interested in, is how frequently do we see Lewy body changes in people who have Alzheimer's disease confirmed by autopsy. And in fact, it's very frequent. Probably in the sporadic Alzheimer's, about 60% have some kind of Lewy body change in their brain. So it can be fairly limited to an area of the brain called the amygdala, but it can be fairly throughout the brain in about a third of Alzheimer patients. We see it in people with Down syndrome who are at high risk for developing Alzheimer's. They also will coexistently develop Lewy body changes. And we even see it, and probably significantly so, in people who have very early onset Alzheimer's due to mutations linked to early onset Alzheimer's. So these are people in their 40s, let's say. They, about 60% of them will also have Lewy body changes in their brain. So I think it's important that there is this link as well here. Probably people who have the Lewy body type symptoms, the Parkinsonism, the hallucinations, the fluctuations, the sleep disturbance we talked about, the REM sleep disorder, they're the ones that have the more diffuse in the brain Lewy body changes like we would see in Parkinson's disease or straight dementia with Lewy bodies. So I'm going to go over a little bit of the clinical story and what we look for in terms of symptoms with the Lewy body dementias. So while we all think about memory loss and Alzheimer's disease, what we typically see more frequently in individuals with the Lewy body disorders is more trouble with executive function. And again, I've already talked about multitasking in particular. We do see the apathy, the sort of decreased interest in activities, probably more depression in the Lewy body dementias than we see in Alzheimer's disease because people have more insight. They tend to have an idea of what's going on. We see a lot more visual spatial dysfunction, which may lead into some of the hallucinations that people see. And we often will see psychotic symptoms, particularly hallucinations. And when they're problematic, it's because they're also linked to false beliefs or delusions. But we can see delusions in straight Alzheimer's disease as well. But the visual hallucinations seem to be specific to people who have some of the Lewy body changes in the brain. So a little bit different than what we typically see in Alzheimer's, and that less of the memory loss, more of the executive dysfunction. So those of you who've ever heard me talk, I share my favorite formed visual hallucination is the guy that said, kind of laughed at himself and said, I look out the backyard and I see squirrels driving tractors out there, which just, of course, fascinated me when he told me this. And he didn't tell me until I asked him, and then his wife looked at me and said, well, there are a lot of squirrels out there, but I can tell you they're not driving tractors. This is a really well-formed visual hallucination. He knew it wasn't really, could laugh at himself. And again, for clinicians, for people who are seeing patients and evaluating, you have to ask about these questions. Are you seeing things? A lot of times early on, people will say, I think somebody's standing next to me, or there's something over there, and I look over and there's nothing there, that sort of sense that something's there. And that can develop into it. A lot of patients are not disturbed by the hallucinations. When they are, it can be difficult to treat, but I will talk a little bit about how we might approach that later. The other major symptom I already mentioned was the REM sleep behavior disorder, strongly linked to Lewy body pathology, acting out of dreams. Really needs to be defined by a sleep study because people can move a lot in their sleep, but it isn't always happening during that specific, the rapid eye movement sleep that REM sleep is. And there are other sleep disturbances that can happen. The one thing about the REM sleep disorder is that it can occur for many years before other symptoms kick in. So there are a number of studies. My colleague Brad Beauvais has been involved in at Mayo Clinic, looking at REM sleep disorder and what causes people to eventually develop some of these other Lewy body disorder symptoms. For when I'm seeing somebody with a Lewy body dementia, and I'm wondering if that's what's going on, obviously I get the history of Parkinson's disease, makes it relatively easy. People who develop dementia in the context of Parkinson's disease are very frequently end up having Parkinson's disease dementia linked to Lewy bodies. When people present with dementia, I may try to determine if they have an abnormal dopamine system like we see in straight Parkinson's disease with the dopamine transporter scan, or a DAT scan, as you might have heard. And there's some other tests we can do. One thing I want to highlight here is that we are seeing, these are markers we use for coexistent Alzheimer's disease. There now is a marker for Lewy body changes, and I'll show you one slide about this, but this is really, I think, revolutionary in my mind in terms of increasing our accuracy of diagnosis for people who are not, where it's unclear, and that can happen in Parkinson's disease as well. Is this in fact a Lewy body Parkinsonism? I'll talk about it again in just a couple of slides. So what we typically see in Parkinson's disease and dementia with Lewy bodies is on the dopamine scan that there's a loss of dopamine going to the brain that controls motor activity. Frequently, it's worse on one side than the other in Parkinson's disease. In dementia with Lewy bodies, it typically is a little bit more even in terms of being down on both sides. So it's not unusual to see people, unlike straight Parkinson's, where I might see an asymmetric, where one hand is involved with a resting tremor. Whereas in dementia with Lewy bodies, people may present with just slowness of movement, not so much classic tremor, and be a little bit more symptoms on both sides. So it's what we would call symmetric. There are changes that we can see on metabolic panels. In particular, as you can see on the bottom here, the visual area of the brain tends to be less active in people who have the Lewy body diseases. And that may explain, this is a part of the brain that actually helps you process visual information. And there's a lot of thought that this may lead to the hallucinations we frequently see in Lewy body disorders. I talked a little bit about looking at dopaminergic input into the heart, which is something that does go down in the Lewy body diseases. As you can see, you've lost that innervation here. You don't see that in Alzheimer's or normal controls, although this is a test that typically we only do more frequently in our cardiac patients. So again, I've kind of mentioned this, but I think this is a really important component to diagnosing the Lewy body disorders, which is we have now been able to detect that alpha-synuclein protein that's in Lewy bodies in its what we call aggregated form in the spinal fluid and sometimes in skin biopsy of people who've had Parkinson's disease or dementia with Lewy bodies. This has really allowed us to be much more careful about making the diagnosis. And again, as I said, feeding into this idea that we could use this to really identify people who we know have a Lewy body changes in their brain that's causing their symptoms. And when we have that new therapy that focuses on treating the Lewy bodies, we're treating the right people. So that's really the critical part. And that's the critical part of what really helped Alzheimer's disease. So you may hear about this RT-QuIC or synuclein aggregate assays that we're using. I know the Michael J. Fox Foundation is very interested in seeing where this goes because they think this is very important in making a biological diagnosis and definition of these diseases. So what do we do to treat the Lewy body dementias? Well, we do a number of things. We do treat them with the drugs that we often use in Alzheimer's disease. And in fact, often they work better than they do in Alzheimer's disease, particularly what we call the cholinesterase inhibitors. So these drugs increase the amount of acetylcholine in the brain, much like your dopamine drugs increase dopamine. These increase the acetylcholine that we know is decreased in Parkinson's and dementia with Lewy bodies. And although not approved for this treatment, often we use this in people who work in the field. This is kind of almost a unanimous feeling that this is something that people do respond better to than they do when they have Alzheimer's disease. And in fact, I'd say clinically, when I see somebody come back and the family says, gee, it's almost like they're back to normal, I wonder if this is in fact a Lewy body patient, not so much an Alzheimer's patient. If we can, we try to avoid the antipsychotics in people who are having hallucinations, particularly if the hallucinations are relatively benign. We do have to frequently use them if people are if people are really having a delusional component, they have a belief that the hallucinations are real and it's very disturbing. That can be a circumstance where we have to treat. But of course, these drugs have significant side effects. So we do want to try to avoid them if we can. If we can't, we start low and go slow. It's sort of the old geriatric statement here that we really want to try to avoid these if possible or use the lowest dose possible. I often use melatonin, sometimes clonazepam, which is a little sedating, so I tend not to use that as much for the REM sleep disorder, but it can help suppress them if they're getting out of hand. And I'll use the typical antidepressants for true depression. This was a study from many years ago looking at using rivastigmine, which is one of the variants of donepezil or Aricept. This comes in a patch formulation they can put on the arm, showing that it did have a significant effect on behavior in people with, in this particular circumstance, dementia with Lewy bodies. This really is, again, old paper, 2000, really opened our eyes to the fact that what we were seeing clinically has some basis in data, actually. This is a paper that just came out, actually, this year, you can see 2023, that really looked at all the papers over the years that have looked at using these drugs for psychotic symptoms in Alzheimer's and Parkinson's disease. And what you can see, generally speaking, and you'll have to look at this part over here, and this is a line where if the drug is doing nothing for, in this case, false beliefs or delusions, and in this case, visual hallucinations, to the left is good. It's reducing the frequency. To the right is bad. It's making them worse. So what you can see is that there is this small effect in Alzheimer's and in Parkinson's disease of these cholinesterase inhibitors, the old Aricept, the rivastigmine patch, helping with these. And particularly, I tend to like to use them in the Lewy body patients that are having not only the hallucinations or just the cognitive changes, because it can help with the thinking skills. It's not sedating, and it actually helps suppress the hallucinations from even coming out. The other thing that it tends to do is it tends to help people's attention. And what we've noticed is that it tends to lead to less fall frequency. So people are a little sharper in the now. That's the kind of memory I typically see improve. People better during a conversation, staying on task. They may not be as better with their memory, the next day, but during the time that they're needing to use it, they're a little bit better there. And what you can see in this study on the left here is they saw a reduction in fall frequency with the use of cholinesterase inhibitors. And you can see on the right, again, this is sort of that effect on behavior, particularly the hallucinations. So what else? So we've talked about the symptomatic treatments. These are not treating the disease itself. And one area that's particularly interesting, besides looking for drugs that can treat the synuclein, the Lewy bodies themselves, is actually, as I mentioned, in the Parkinson's dementia study we did with autopsy, and in a study I'm involved with called the Lewy Body Consortium, where we're looking at people who've developed memory issues first, dementia first, and then later Parkinson's symptoms, et cetera, that many of them have the changes of Alzheimer's disease. Probably 20 to 30% have the full changes of Alzheimer's, and probably almost half may have some of the amyloid changes that we see linked to that. The reason that's important is this lower part here on the right, is that we now have a drug that's been approved by the FDA for treating the amyloid in Alzheimer's disease. Particularly in the earliest stages, it seems to have an effect on getting rid of the amyloid, and it seems to have an effect on in slowing the progression of the disease. So I think there's a lot of discussion. I've had a number of discussions over the last several months of a trial in people with Parkinson's dementia who have confirmed coexistent Alzheimer's or Alzheimer changes and dementia with Lewy bodies to see if we may get a benefit from these amyloid drugs. These drugs are complicated to give, and they do have side effects. So we're thinking this out, but this is something you may see in the future. And this is what we would call a disease-modifying therapy. It's not just treating symptoms, but actually treating the disease itself. So kind of what's next? In the area of dementia, there has been this National Alzheimer's Program Act, or NAPA, that is really focused on what are the important things to fund from the National Institute on Health in the dementia area. And there has been some focus on the Lewy body dementias, and there's a number of recommendations that were made. First and foremost is we've had longitudinal studies of Alzheimer's disease since the 1980s. So that's, how many decades now? 4 decades of research. We really haven't had that in the Lewy body dementias area. And that's been very important. And that's partly what the PPMI study was developed for. And we And the NIH recognized this and put out a request for applications to do this kind of fundamental research with people who develop these disorders. And in 2016, they funded 5 sites, including a Dementia with Lewy Body Consortium that I led at that time, from around the country. And in our study, basically, we were doing what the Alzheimer's Center has been doing for a number of years, which is identifying people with dementia with Lewy bodies or Parkinson's dementia and following them longitudinally, capturing their symptoms, capturing blood samples, doing spinal fluid testing, and ultimately, if they agreed, to having autopsies to link this all together, and creating a lot of basis of which other people to do research on as well. And this study has been very successful from that perspective. For the first 5 years, we've collected almost 10,000 biofluid samples for these individuals, and we've enrolled about 160 individuals in this study. So it's been a successful study. We brought together this study, a number of people from the East and West Coast. It was nothing against the Midwest. It was just that's the people that we knew that we linked into applying for this grant. And you can see a number of us in the Northeast area, North Carolina, Florida, California, Nevada, and Washington State. And after the 5 years of that study and these 10,000 samples and 160 enrollees, we submitted for the study to be renewed, but the renewal required that we had some hypotheses. This wasn't just characterizing individuals, but trying to make some educated guesses to what's going on, particularly what's causing dementia in individuals, and how can we study that in people, not at autopsy, but when they're alive, when it really counts. So the aims of this study really were to continue to expand the research study group. So we're aiming to ultimately get more than the 250 participants that we're following longitudinally, to look at things we call satin biomarkers. So these are blood and spinal fluid markers for synuclein, the S, amyloid they talked about in Alzheimer's, the tau we sometimes see in Alzheimer's, inflammation, which is increasingly an important marker, and what we call neurodegeneration or change over time. And really to look at how that links in, and can we identify those components? Partly for diagnostic accuracy, but also as we start to develop new therapies, for example, an anti-inflammatory. What do these anti-inflammatories look like? How will they change as we give these treatments? These sorts of things are really important as we try to get better at managing these diseases, treating these diseases directly. We also want to develop further those synuclein aggregate assays I mentioned. They're so important in diagnosis. In particular, we want to see, can we develop this test in blood? So we can screen a larger number of people without spinal fluid testing. Can we quantify it? In other words, could that be a marker for a disease, let's say a disease treatment that's trying to treat the Lewy bodies themselves? Can we use these biomarkers to say, yeah, we're getting rid of it. We're changing the levels of those aggregate proteins in the spinal fluid, in the blood, in the biopsies, skin biopsies, these sorts of things. Again, critical to developing these new therapies. So we're very excited about this research. We're just moving into our second year of this 5-year study, but already we're applying these, particularly synuclein aggregate assays, these Lewy body assays, to the groups that we've already been following. So this study continues across the country. We are looking to add a few sites, particularly one in the Maryland area. But if you see one close to you and you want to participate, you can certainly reach out to us. We have the Dementia with Lewy Body Consortium has a website that you can go to. So I'm going to stop there. And of course, there are innumerable people I need to thank for all the work that I presented over the years. But I particularly want to thank the NIH for supporting our work, Lewy Body Dementia Association. And I'll leave it there for right now And do you have any questions for me?
Thank you so much. So if someone who's had Parkinson's for 10 or 20 years and they get the diagnosis of dementia, what's the first thing you ask families to do? What's the best thing that they can do when they get that new addition to the diagnosis?
Well, probably I'll look at what the situation is like, safety issues, things of that nature. I want to know what their major symptoms are. What the old adage, you've seen one Parkinson's patient, you've seen one Parkinson's patient. So everybody's a little bit different in what the major issues are. So I try to get to, what are the issues that need to be dealt with now? And then that'll guide my therapeutic intervention, and try to make sure. And that can be something as simple as working with a social worker, and getting help at home, to, some of the therapies I mentioned. I do, as you probably could tell already, I do like to give the cholinergic drugs, in addition to the standard dopamine drugs that we give to people with Parkinson's disease for their motor symptoms, because of the cognitive benefit we tend to see in the reduction in some of the side effects like the hallucinations.
Do you have one definitive test you lean on for a diagnosis when it comes to dementia with Lewy body?
Not really.
Okay.
Because we know that aggregate assay I talked about, that can be positive in people who just have the REM sleep disorder and are totally cognitively normal. So it really is a linking together of what are the functional changes we're seeing, what are we seeing on the testing, the memory testing. I do tend to use something called the MoCA more often than the mini mental, because that has a little more sensitivity to some of the changes we see in the Lewy body dementias than in, say, Alzheimer's disease. And I want to make sure also that there's nothing else going on. Oftentimes, there are multiple factors that are contributing. And so, for example, it's not unusual for a Parkinson patient to develop a delirium if they have another infection, for example. So acute confusion. And I want to make sure I'm not missing something there. Is there some inflammatory process or something else going on that might be sending them down this path at this point? So I want to make sure, even if that's not the only contributor, that it's something that we can address, right? You can treat a urinary tract infection, you can treat a pneumonia.
And do you encourage patients, when it comes to the dementia piece, to be doing cognitive therapy, getting hooked up with the speech therapist for those pieces once that diagnosis comes onto their record?
That's a really good question. We do tend to use our speech therapist for cognitive rehab. We do tend to get to focus more on people at the mild cognitive impairment level, or maybe the very mild dementia stage, just for the level of interaction needed. But yeah, we do get some benefit there, and just particularly some ideas about how to manage weaknesses and also to lean on strengths. As I said, particularly in Parkinson's dementia, people tend to have more insight to the changes they're experiencing, which has its downside, right? But in Alzheimer's patients, typically, they're saying, no, everything's fine, I'm doing just fine. And, the spouse behind them is shaking their head, no. Whereas in my Parkinson patients, typically they're telling me, yeah, I'm noticing some changes. And so you can interact with them and strategize with them.
Yeah. Well, you did such a good job with that presentation. The other questions I had, you already answered. So thank you so much for your time and working with us to get this together.
Great. Thanks for having me again.
No problem.
Good day. Bye-bye.